Welcome to the Bariatric Surgery Program at New York City Health and Hospitals Metropolitan, located in the East Harlem neighborhood of New York City. Our program consists of 3 surgeons, Dr. Daniel Stevens, Dr. Dustin Cummings, and Dr. Umashankar Kannan, and our dietitian, Elisa Luning. For this presentation, we will discuss trends in obesity, surgical options to treat obesity, specifically sleeve gastrectomy, and then we will have a discussion on nutrition. With regard to obesity in the United States, the prevalence is around 42.4% as recently as 2017 and 2018, and the number is only increasing. Nearly 10% of the U.S. population suffers from severe obesity. Medical costs of obesity are increasing. As recently as a few decades ago, it was up to $147 billion, and that number is only increasing. The individual person who suffers from obesity can expect to spend $1,500 more than a person who is not obese. The perceptions of obesity are changing. In decades past, obesity was thought to be a weakness of the individual, and diet and exercise were the only options to treat this condition. But as we now know with new research, obesity is a complex interaction of genetic, environmental, and behavioral factors. Surgery, specifically bariatric surgery, is the proven and safest method for achieving sustainable weight loss in conjunction with diet and physical activity. So the way that we calculate obesity is by using the BMI formula, whereby we divide one's body weight by the square of their height. Candidates for bariatric surgery have to meet the following criteria. You must have a BMI of 40 or greater, or a BMI of 35, including the following comorbidities, such as diabetes, high blood pressure, high cholesterol, snoring or obstructive sleep apnea, as well as an inability to lose weight with medical treatment alone. In regards to bariatric surgery, there are people who do not qualify for bariatric surgery, include patients with severe heart failure, unstable coronary artery disease, end-stage lung disease, active cancer, uncontrolled drug or alcohol dependency, severely impaired intellectual capacity, or current or planned pregnancy within the next 1 to 2 years. This slide shows illustrations to give a better idea of the classes of obesity. The 3 silhouettes to the left incorporate people of normal weight, overweight, or obese. The 2 silhouettes to the right include people who are obese and extremely obese, and the silhouettes on the right are the people who we would consider for bariatric surgery, class 2 obesity and class 3 obesity. Obese patients face higher health risks and an increased risk of mortality, as their rates of the following conditions are greater than patients with normal rate. Those conditions include diabetes, hypertension, sleep apnea, depression, joint pain, infertility, cancer, acid reflux, and asthma. There are various weight loss strategies that may help patients seeking to lose weight, such as nutrition, physical activity, behavioral, and drug treatments. Of note, these various treatments only have about 5 to 10% effectiveness for durable weight loss. There are several surgical options within the domain of bariatric surgery to help patients achieve sustained weight loss. 3 of those include the lap band, the sleeve gastrectomy, and the gastric bypass. They differ in their surgical approach and the changes to a patient's anatomy, and we will go into each of them separately. The number of bariatric surgeries performed in the United States continues to increase. As we can see, as most recently as 2019, the sleeve gastrectomy has become the most popular bariatric surgery, followed by the gastric bypass. The laparoscopic band surgery is not frequently performed. It is notable because there is no stapling, intestinal rerouting, cutting. It requires an implanted medical device. It is adjustable and reversible. There is slower weight loss compared to the sleeve gastrectomy and the gastric bypass. Approximately 10 to 15% of patients fail to lose weight. There is a low malnutrition risk with this surgery. The laparoscopic gastric bypass is the most well-known bariatric surgery and has the greatest history behind it. It is notable for minimally invasive incisions. There is stapling, intestinal rerouting, and cutting of the stomach and the small intestine. It is reversible, but it is very difficult to reverse. Weight loss is greater than the sleeve gastrectomy and the lap band. There is a malnutrition risk, which is greater than the sleeve gastrectomy and the lap band. There is dumping syndrome associated with the gastric bypass. The symptoms of dumping syndrome include bloating, diarrhea, flushing, and cramping. The laparoscopic sleeve gastrectomy is the most popular bariatric surgery performed in the United States. More than 75% of the stomach is removed during this minimally invasive procedure, and the end result is a stomach shaped like a banana. A portion of the stomach that is removed is responsible for producing ghrelin, which is the appetite hormone. So patients will experience less hunger than they would have before the surgery. Stapling is involved, but there is no intestinal rerouting. This surgery is not able to be reversed. It is restrictive, so your stomach holds less food and you feel fuller. There are fewer complications than with the gastric bypass, and there is almost similar weight loss. In terms of risks and complications, bariatric surgery is safe. The risk of short-term mortality is less than 1%, 0.19% to be exact. The risk of leak is less than 1%. There is a risk of bleeding, reflux, stricture, and reoperation. In terms of results from sleeve gastrectomy, the percentage of excess weight loss ranges between 33 and 85%, with a mean excess weight loss of 60%. Many patients experience an improvement or complete resolution of their comorbid medical conditions. For example, patients with diabetes can experience between a 69 to 100% resolution or improvement. Patients with high blood pressure or hypertension can experience between a 31 to 100% improvement or resolution of their symptoms. For patients who are interested in bariatric surgery, the preoperative workup can take between 2 and 3 months. During this evaluation, patients will see several specialists, including cardiology, pulmonology, psychosocial assessment with a social worker, and a registered dietitian for nutrition. Patients will also receive an upper endoscopy to evaluate their anatomy prior to surgery. Patients who are interested in bariatric surgery, they are also recommended to lose some weight preoperatively and refrain from alcohol and tobacco usage for 4 to 6 months prior to surgery. In terms of recovery, the surgical operation takes between 1 and 2 hours. The hospital stay typically lasts between 1 and 2 days. Patients may begin drinking on the day after surgery. Patients are asked to adhere to a liquid and soft diet for 4 weeks after surgery as their stomach heals. They may resume a solid diet after 1 month. Patients typically return to work within 2 weeks, and they resume strenuous activity within 4 to 6 weeks. In terms of pregnancy after bariatric surgery, weight stabilizes within 18 to 24 months after surgery. We recommend that patients do not get pregnant for at least 18 months after surgery. There is a risk of low birth weight and fetal developmental delays if this does occur.